Good morning. We are on time today. Welcome to the Interim Retirement and Benefits Committee meeting today. And with that, I'll ask, please call the roll.
Assemblymember Carter.
Present.
Assemblymember Gurr.
Here.
Vice Chair Monroe Moreno. Senator Orenshaw.
Present.
Senator Stone.
Here.
Chair Dondora Loop.
Here, and please mark Assemblywoman Vice Chair Danielle Monroe Moreno, absent, excused. And we will go to the next thing on the agenda, which is public comment. And to provide public comment or testimony, please call 888-475-4499. And when prompted, provide the meeting ID 861-7260-3549 and press pound. So with that, we will go to public comment number 1. Please go ahead. Here in Carson City, or there in Carson City? Here in Las Vegas? Oh, is there one in Carson City? Okay, go ahead, please.
All right, thank you so much. Good morning, Chair Dondera Loop and fellow committee members. My name for the record is Terry Laird, and I'm the Executive Director at RPEN, the Retired Public Employees of Nevada. We are a nonprofit, nonpartisan, federally tax-exempt organization created in 1976-77, and we have nearly 7,000 dues-paying members throughout the state in 17 chapters. Our primary purpose these last nearly 50 years is to protect the pension earned by all of our members while working, as well as lobbying to make their health care benefits more affordable. We are grateful that the 2023 legislative session was able to increase wages earned by state employees who have always been paid less than their city and county government counterparts. We also are aware that the Nevada State Police loses troopers regularly who hire in and are trained at the state level only to leave soon after for city and county law enforcement agencies who pay more. Additionally, we know that PERS has to adjust contribution rates paid by state employers and employees prior to every legislative session. In recent years, those contribution rates have risen rapidly, especially for entry-level employees who also are paying higher premiums for health insurance, leaving little for them to live on. In addition, any state employee hired after 2011 will never receive retiree health care benefits because of cuts the legislature had to make that year. So it's no wonder hiring is suffering in many state agencies like the DMV, DETR, even at PEB. This is a great concern for us as we head into another legislative session. We are here today to acknowledge our continuous support for Nevada's PERS and PEB agencies, and hope lawmakers will again see fit to do what's necessary to hire more workers, pay more, and in the end lower those contribution rates. Today's state employees are working to support our current retirees, and we are thankful for them, and also want them to be able to have a livable wage and affordable health care while working, as well as when they retire. Thank you.
Thank you very much. Go ahead, please.
Good morning, Kent Ervin, Kentervin for the Nevada Faculty Alliance, NFA, representing professional employees at Nevada's public colleges and universities for the record. Chair Dondera Loop, Vice Chair Monroe Moreno, and members, thank you for overseeing the Public Employees Benefits Program. We have submitted written comments on both PEB and PERS. We have 3 major concerns that I'll give here. First, NFA opposes PEB's proposed elimination of the Health Maintenance Organization HMO EPO plan option. Many employees depend on the HMO for predictable out-of-pocket costs, and they are willing to pay extra monthly for that security. Especially in Clark County, essential providers, including mental health and other specialties, are only available on the HMO network. Second, after years of generating excess reserves, PEB had a deficit in mandatory reserves of about $26 million at the end of FY 2024 and has a projected deficit of about $66 million for this fiscal year. The budget for PEB in the next session must maintain current benefits and employee premiums and replenish the reserves. Third, the PERS, retirement system contribution rate increase, will reduce our employee paychecks by 1.75%. With inflation running at about 3%, cost of living adjustments of 5% in FY 2026 and 3% in FY 2027 are required just to stay even. At least maintaining health care benefits and the value of take-home pay for state employees is critical to keep from falling behind in recruitment and retention. These should be top priorities next session. Thank you.
Thank you very much. Is there anyone else in Carson City? Seeing none, I will go to Las Vegas again. Seeing none in Las Vegas, we'll go to the phone lines. BPS, when you're ready.
Thank you, Chair. The public line is open and working, but we have no callers at this time.
Okay, thank you very much. All right, with that, we will go on to the approval of the minutes of January 16th, 2024, which seems like eons ago, but we will go to that. So I will ask for an approval from Senator Stone, a second from Assemblyman Carter. Thank you.
Second.
And with that, all those in favor say aye.
Aye.
Aye. All those opposed? Motion passes. Thank you very much. And we will go on to agenda item 4. And we'll start with the presentation from PEB. I believe Ms. Glover is up in Carson City. Nice to see you. We're glad you're back.
Morning.
Go ahead, please, when you're ready up north.
Good morning. My name is Celestina Glover. I serve as the Executive Officer for the Public Employees Benefits Program, and with me I have Michelle Whalen. She serves as the Chief Financial Officer for the Public Employees Benefits Program. Good morning, Chair and members of the committee. Today we're going to present to you an overview of what has been going on with PEB for about the last year. Much of this information you have seen in the past, but we will continue to provide that information and update it as it changes. So the first thing you will see on your presentation slides on the screen is just an overview of what PEB does. We are obviously the health insurance plan for the state. We offer 3 self-funded plans and 1 fully insured, which is the HMO plan down in Las Vegas. We also offer a host of voluntary benefits. Some of those listed on your screen include voluntary life insurance, so that's a buy-up from what PEB and the state offers, long-term disability, vision buy-up, home and auto insurance, pet insurance, and a host of other voluntary benefits that the members can enroll in during the open enrollment period. We serve state actives, retirees, and their dependents. We also have a small number of local government employees. At last check, there was approximately 8 employees. Retirees and their dependents. We have a few thousand of the local government retirees, just under 500 on the self-funded plans in the HMO, and the remaining are on the Medicare exchange. We are funded through what we refer to as AGIS, which is an active employee group insurance, and then REGI, which is a retired employees group insurance. That funding is determined by PEB during the budget building process and goes through the budgeting process and ultimately approved by the legislature during the sessions. And what we have on the screen is a little bit more detail on which plans are offered. So for the self-funded plans, we have the consumer-driven health plan, which is our high deductible plan. That high deductible plan complies with IRS rules so that we can offer a health savings account. For those that don't qualify for a health savings account and retirees, we offer a health reimbursement arrangement. We have the exclusive provider plan, which is the self-funded plan in the north as a counterpart to the HMO in the south. It's not exactly like the HMO. It is a PPO type plan, but those rates are blended with the HMO. So if you're in the HMO in the south or in the EPO in the north, you would both pay the same premium for the same tier. So single persons, a member with their spouse or family members, each tier is the same rate. We also recently, and I would say recently in the last 3 years, have offered the low deductible plan. We refer to it as a low deductible PPO plan, but in actual fact, there is no deductible associated with this plan at this point in time. That was a change that was made for plan year 2023, I believe. And so with that plan, it is exactly what it says. It's a PPO. It's a traditional PPO plan. And that is a statewide plan, as is the consumer-driven health plan. Those plans are also offered nationwide. So we have retirees and a couple of employees that actually are out of state. And those are the two offerings that those individuals would have access to. Our fully insured plan is a health maintenance organization in the South that's offered by Health Plan of Nevada. And then we have the Medicare exchange. So our Medicare retirees, if they're eligible for Part A free, they move on to the exchange, and they're in an individual marketplace, and they can opt for any advantage or supplemental type plans that are offered by the carriers on that exchange. They are provided a health reimbursement arrangement based on their years of service. Currently, that is $13 a month per year of service with a max of 20 years. So the next slide will enter into the description of what so far has been approved by the PEB board and is included in our agency request budget. Whether it gets approved or not is beyond me at this point. So this is what we're asking for and how we get there. So each year in September, staff will bring ideas to the board regarding plan design, benefit changes, anything that we believe the board should consider. We have that analysis done by our consultants and other vendors to make sure that we have as accurate information as possible so that we can present that to the board. The analysis recommendations are brought back to the PEB board for their review and approval. And that is usually done at the November-December meeting. The November meeting sometimes slides into December. And then finally, once those plan design changes, if any changes are approved or made, the plan documents are updated. We have to set the rates for those plans. That is based on experience and trend in the marketplace and based on what our plans actually experience. And then open enrollment begins May 1st and ends on May 31st, at which time, if you choose not to change your plan, you don't have to do anything. If you choose to change your plan, this is the period of time that you have to go in and make those elections. For the upcoming plan year 2026, we are proposing that the life insurance be set at $25,000 for employees and $12,500 for retirees, which is consistent with what we have done in the last few years. Currently, a portion of that is paid by the plan with the funding provided, and the other portion was supported by general funds. We're proposing that this all be included in the plan funding rather than splitting up that amount. We've had discussions about trying to keep that life insurance consistent and not always use it as one of the moving targets for plan changes if we're forced into reducing our budgets due to economic downturns and various other reasons where we might have to make budget cuts. We're also proposing a $700 HSA or health reimbursement contribution for the primary member and $200 per dependent up to a max of 3. This is on the CDHP plan. The CDHP is the only plan that qualifies for a health savings account, so that is the only place we can offer that. This is similar to what we did prior to COVID, where we provided funding to dependents as well as the primary. The board so far has approved these 2 items. That was done at the September meeting, and that's what we will create rates for in the new plan. The deductible will increase on the CDHP from $1,600 for a single person and $3,200 for a family, up to $1,650 and $3,300 respectively, and that is due to IRS rules. We bring it to the board for approval, but if they want to maintain that plan, they really don't have an option but to comply with IRS rules. These are the minimum deductibles that we're allowed to have on those plans. If we drop below that, then we no longer qualify for an HSA and we would have to eliminate that offering. The HSA, HRA, and life insurance benefits changes are again dependent on inclusion in the governor's recommended budget and ultimately approval of the funding during the 2025 legislative session. So the next set of slides you're going to see are the utilization reports. The utilization reports in your packet starts on page 108. What I've provided in the slides is just a brief summary of what we're seeing in the various self-funded plans as well as the HMO plan. So this first slide, you'll see that we've listed our enrollment in the CDHP. We have seen a decrease in the primary members by approximately 10% overall, which would include dependents, a 12% decrease. The plan spend per member, though, has actually increased at 6.5% for the primary and 8.9% when you consider dependents and primaries both. The total spend, though, actually decreased by 4.1% for the plan and 4.6% for the employee. So that was good for both of our groups, the program itself and the employees. The next table on that slide gives you the high-cost claimant counts. We look at these because the high-cost claims actually drive the plan cost. These are on this particular plan, high-cost claims are considered to be claims over $100,000. High-cost claims per 1,000 is at 5.2. That is a little bit of an increase over the year before. Percent of plan paid, it's the equivalent of 33.6% of the total plan spend. That was actually a little bit of a decrease. That means those high-cost claims were a little bit lower in total, but it's still 33% of our claims is significant. Emergency room visits per 1,000, we saw a slight increase at 5.2%, and paid per visit, also a slight increase at 5.8%. The utilization for pharmacy, net claims, we saw a 9.4% decrease. This could be a combination of the decrease in the number of members. It could also be a decrease in the need of those members accessing the pharmacy benefits. The gross cost of those benefits, though, did increase by 1.3%. The plan on a per member per month basis, the cost increased by 17.3%, and the average plan share per claim increased 13.6%. And the members are paying an additional 5.8%. I went back and looked at the cost of our pharmacy spend, and this is just for claims, no administrative costs were considered. And between 2022 and 2024, the fiscal years, we saw it go from 59 million in a year to 89 million. So we've seen a $30 million increase over 3 years. And that is very significant. So something we are watching, but we have a lot of specialty drugs, new medications come on the market, and none of those are inexpensive. The next slide gives you an idea of the spend for our top 10 diagnoses. I won't read all of them, but you'll see that cancer, cardiac disorders, and gastrointestinal disorders are top 3 for the consumer-driven health plan. This comes from a list of about 25 different disorders or diagnosis categories that are considered. These just happen to be the top spend for this plan. That changes year over year depending on the health situation of the members. You'll be able to see the detail on that on page 131 in your packet. The next slide gives you the same information as I presented for the CDHP. This, however, is for the low deductible plan. Again, the high cost claims are for those claims over 100,000. You'll notice that enrollment has increased significantly. We're finding that as members are starting to actually research their plans and their options, that we have more and more people that are moving off the PO, the HMO, and the CDHP, and they're moving into the low deductible plan, which is what we expected to see. So that's where you'll see the 35.6% increase for primaries and the 33.7% increase when you look at all members combined. The plan spend obviously increased as well. As enrollment goes up and people learn how to use their plan, we would expect that cost to go up. It went up 10.2% over the previous year, and overall it's an 11.8% increase over the previous year when you include dependents in the total count. Total spend for the plan was 49.4%, higher than previously, and the employee spend also 46.1%. Again, that's driven by enrollment, and as our members learn how to use their plan, they're accessing care more and more. We had an increase again in our high cost claimant, and we had an increase in our emergency room visits, and that table shows you what those increases are. And you can find the high cost claimant enrollment increases on page 152 of your packet, and the ER detail, the emergency room visits, on 158. And then you have the spend for pharmacy. Again, all increases in all categories. This is to be expected as we see more and more members opt to enroll in the low deductible plan. And you'll see the detail on the pharmacy spend on page 171 of your packet. And the next slide again shows you our top 10 diagnoses. And again, those will change year over year depending on the medical conditions that our members are going to seek care for. Cancer tends to stay in that top 3, top 5 situation, cardiac also. So it's not unusual to see these numbers where they are. You'll see that cancer was 8.4% of total spend for this particular plan. And the gastrointestinal disorders, which was higher in this plan than it was in the CDHP, it accounted for 8.7% of total plan spend. And then the next slide gives you, again, the same information for the exclusive provider organization or the EPO plan. You'll notice that we're seeing decrease in enrollment. Again, a lot of those members are enrolling in the low deductible plan. Some are going to the high deductible, but for the most part, they are going to the low deductible plan. Plan per member, even though enrollment's going down, the cost for those members is increasing. 6% for the primary, and 6.5% when you consider dependents. Total spend on the plan, though, did decrease by 5%, and the employee went down by 4.2%. Part of that is driven by the lower enrollment. The high-cost claimants, you'll see those were increased, as were the emergency room visits. Again, this is for those claims that are over $100,000 for the high-cost claimants, and emergency room visits is exactly that. RX utilization, the net claims was a decrease. Part of that is driven by the enrollment. But the gross cost, the PMPM for the plan cost, the average plan share per claim, and the member share per claim all increased. And you'll note that the plan cost, PMPM, actually went up 20%. And that, again, is driven by the cost of medications overall. And as I said, we've seen a significant increase in spend in our pharmacy benefits. And then our top 10 diagnosis areas, again, cancer is up there in that top 5, top 3 in this case. They are 10.3% of the spend in this particular plan. Cardiac is 8.3%, and the gastrointestinal disorders 8.1% of total spend. So you'll note from all 3 plans that the top 3 tend to be very similar. It's just who gets the number 1 spot versus the number 3 spot. And then the last one is the HMO. We look for the same information. They provide that data to us. You will find their utilization starting on page 198. The enrollment is on page 201. So we're seeing a decrease. Again, those folks tend to be moving into the low deductible plan. As people are looking for the best bang for their buck, part of that is the cost of the monthly premium. And so that often does cause individuals to move over. And of course, their individual health concerns also would affect their decisions in that area. The plan spend per member, we're seeing a decrease for the primary and the overall, and that's a pretty significant decrease over the previous year. It's not a decrease to PEB per se, because PEB pays a premium to Health Plan of Nevada. We don't pay for the individual claims, but that is what the HMO is reporting, that it's overall, it's per member, it's a lower spend. And total spend for the plan, 29% decrease, employee 27.1% decrease. Again, this is not claims payments made by PEB. This is claims payment made by the HMO. The rate that PEB pays actually went up 12% for this current plan year. So we saw a double-digit increase. High dollar claims for them is at 50,000, so they report their numbers a little bit different than we do for the self-funded plans. We had no change in the number of high-cost claims from the previous year, and we saw a 4.6% decrease in the percent of plan paid. But we did see a significant increase in emergency room visits with a 6.9% when you're considering visits per 1,000, and the amount paid per visit also went up by 14.6%. And then their RX utilization, the member enrollment obviously was down because we had a decrease overall enrollment in the plan. Average paid per prescription, the HMO is having a similar concern with the cost of pharmacy, and that was an increase of 2.3%. The net paid PMPM was a 4.3% increase. So although enrollment went down, the cost is still going up. And then the HMO net paid plans for the 10 common conditions. You will see those on page 211 of your packet. And this lists mental disorders as their first one. Breast cancer, so another cancer disorder, is their third one. And we're seeing that the mental disorders in the case of the HMO is 11% of the plan spend. And then breast cancer is only 0.8% of their total plan spend, but they did spend $739 PMPM. And again, the HMO reports their data slightly differently than we look at the data for the self-funded plans. With that, I will stop for a minute to see if there are any questions, because that was a lot of information.
Thank you so much, and I appreciate you giving us that information. And I would see if there are any questions, and we'll go up north first.
Chair Dondera Loop.
Senator, thank you, Senator Orenshaw. Go ahead, please.
Thank you. And with the chair's indulgence, I have a few, if I might continue.
Please go ahead.
Thank you, Chair. My first question, and thank you for the presentation. The HMO plan seemed like it had a smaller decrease in enrollment compared to some of the other plans, but it also seemed like it had a smaller increase in the pharmacy costs compared to the plans that had had a bigger decrease. And I just wondered, what do you attribute that to? It seems like it's the pharmacy costs haven't gone up as much, even though, you know, the others have less enrollment but higher pharmacy costs.
This is Celestina Glover for the record. The only thing I can say is that the HMO plan has the traditional gatekeeper model, so they have more cost-saving measures in place that they can use. We do have a smaller population. That is probably our smallest population in total in all of our enrollment. So the decreases, seeing that decrease or increase being at a smaller rate isn't surprising. But specifically what they're being seen for or what is causing the members to access whatever care, that I can't really answer. I would have to come back to you with more data in that area.
Okay, thank you. I appreciate that. And if that's something you can obtain with the chair's permission, I'd sure appreciate that data if that's okay with the chair. And if a couple of follow-ups with the chair's indulgence. You mentioned on the HMO plan, I think I saw a decrease of 3% on the HMO plan. Do you have a breakdown as to whether that decrease maybe in Southern Nevada versus, Reno, Carson, Douglas, the rest of the state? Is the decrease uniform throughout, or I wonder if you have it broken down either by region or county?
This is Celestina Glover for the record. The HMO plan is only offered down in the Clark County area, so it is all Southern members. They're the only ones that can access that plan. The North, the answer is the EPO plan, and that, even with that, there's pretty significant restrictions as to the regional area that plan is offered.
Thank you very much. I appreciate you explaining that. And I guess the other question I have is, can you discuss the viability of continuing the EPO and HMO plans, given that decreasing enrollment and the increase that you mentioned in your slides of the per month, per participant costs?
Yes, this is Celestina Glover for the record. We have been looking at both the HMO and the EPO plans since I came back on in May of 2023. We are consistently seeing enrollment decrease in those plans. We also know that a lot of our sicker members opt to enroll in those particular plans because of the payment structure. So we will hear people indicate that they know what their out-of-pocket costs are going to be. So if it's $50 for a doctor's visit or $100 for, a specialist visit, whatever the actual cost is, that drives them into the plan because of their consistent care that they're looking for versus somebody who goes for an annual visit once a year and doesn't have any major health concerns. We saw double-digit increases for plan rates. Keep in mind, the EPO is a self-funded plan, so that is funded by state dollars and run by our agency plus our vendors that assist us, or our third-party administrator. We are not a profit-making organization. The HMO also has a profit on top of what our costs are. Obviously, they need money to stay in business, so we are not surprised by that. Our analysis is showing that these plans are becoming more and more difficult to maintain simply because the enrollment continues to go down, but the costs continue to go up overall. What we pay the HMO, what we pay for claims on the EPO, they're just getting to a point that they're becoming unsustainable. Where that magic number is, it depends on how you look at those numbers. When I speak with my consultants, they say we're already at that enrollment threshold where much more of a drop, we can't sustain it. We typically, what happens is healthy people tend to subsidize the unhealthy people in a plan. Well, if there's no healthy people opting to stay in those plans because the premiums are too high, they're moving out of that, and there's no way to balance it out with the HMO. With the EPO, those folks are rated with our other self-funded plans, but the EPO is not a true HMO plan. It's not a gatekeeper model. It's essentially a PPO. So we are really watching those numbers to see what that looks like. I think we are at a point where, as much as we know our members that are on those plans are concerned, we really believe it's getting to a point where it's just not going to continue to be sustainable without some significant either increase enrollment, so more people that are healthy go into those plans, and the rates coming down. A single person on the HMO and EPO, which those rates are combined so that they pay the same as I said earlier, they're looking at $100 a month more in premium for those plans. What we proposed in our September meeting, which the board is going to look at again in its January meeting, is to structure the payment methodology in the low deductible plan to essentially mirror or mimic the HMO. So there is a definite copay, there's not co-insurance. I'm proposing no deductible. So a lot of the concerns that members have talked about, knowing what's coming out of their pocket, every time they go to the doctor, they would still have that same option, but we'd be able to better utilize the dollars that we have available to pay for the cost of those plans if we can bring them down to having the two self-funded plans versus having an HMO in the south and the EPO in the north. It's, like I said, the last renewal was double-digit renewal. It was 12%. We were expecting 28, but they were able to crunch some numbers. We do know at some point that HMO isn't going to continue to be able to give us a better rate than what the claims experience really is showing when you look at those numbers. So at this point, I think we're at that. We're at that threshold where we need to make that decision. We need to make it soon.
I appreciate the answer, and I thank you for what you're doing to try to protect members and help their access to health care. Chair, thank you very much for those questions.
Thank you very much. And anyone else up north with a question? Seeing none, we'll come down south. Senator Stone.
Thank you, Madam Chair. Merry Christmas to everybody. Happy Hanukkah. Thank you for the presentation. It seems like the number one expenditure is for cancer treatments. And in Nevada, we have a shortage, as you know, of healthcare professionals, especially in the oncology realm. As an example, if you need a bone marrow transplant, if you have non-Hodgkin's lymphoma, chances are you need to leave the state and find someplace like Stanford University, Mayo Clinic to get this state-of-the-art treatment. And it seems to be, again, the largest expenditure, and probably I would imagine some of the higher dollar claims that we have. Do we know what percentage of our cancer patients are seeing professionals domestically here versus going out of state? Because I think we probably could control costs within the state, but probably outside the state, we probably have more difficulty in controlling the costs. Do you have any numbers on that at all?
This is Celestina Glover for the record. I don't have specific numbers on that. I can tell you that we do know, Huntsman Institute in Utah is one of our in-network providers, and we do know that a number of our members are referred to Huntsman as well as Stanford and some other facilities. We have recently started a contract, this was a year ago, for essentially oncology concierge services so that our members can be helped with navigating the best place for their care, whether it's domestically or out of state. Because, depending on the type of cancer, if it's a breast cancer, maybe they are being helped here, but if it's some other more rare form of cancer, the specialist may not be here. I don't know specifically what that breakdown is, but I can go back and see if I can't get that data and provide it to staff.
Well, thank you for that. And I assume that the high costs of the cancer treatments is probably a function of also the cost of the pharmaceuticals and the chemotherapy, which takes me to my next question. So I think you'll see in the 2025 session that there's going to be some BDRs on pharmacy benefit managers. Those are the intermediaries between patients, insurance companies, and pharmacies that are getting paid for claims. And the PBMs originally were just a switch, if you will, a conduit between these entities. And when you have 80%, 85% of them controlled by 3 or 4 companies, they decided to monetize that, and they're now multi-billion-dollar companies. So the question is, for our APO plans, do we have one PBM or multiple PBMs? And has there ever been an idea to form our own state PBM so that, number one, we can control the formulary, and number 2, we can get the rebates from the drug companies based on what drugs are put on that formulary. And thereby we can reduce what you saw in multiple slides, the increase in the cost of pharmaceuticals to the state, and certainly copays to our employees, and share those savings and try to reduce the cost of pharmaceuticals rather than every year come here and see the inflationary increases. Understanding that the PBMs are kind of a black box and we don't know what goes on the inside of that box. And but we do know that it is a profit center, and we need to make that profit center a part of the state of Nevada for the benefit of the beneficiaries, which is 3.2 million people here that depend on us to try to keep their healthcare costs as low as possible.
This is Celestina Glover for the record. So for PEB, we have one PBM for all 3 of our self-funded plans. The HMO pharmacy is taken care of by Health Plan of Nevada. The costs obviously are high. They're driven by a combination of what it costs to pay the PBM for the claims and their admin fees, what the pharmaceutical companies are charging, as well as what the pharmacies themselves are charging. I will say that we do get rebates, and that does help us fund the plan. Those rebates over time have gone up, so we are seeing an increase in what we're getting back to help us pay for those claims. I believe there has been some talk in the past about the possibility of pooling resources between the various entities within the state of Nevada to try to use our buying power to lower the cost of drugs. I don't know if there's been any push to create our own PBM, so to speak. Having the resources and the expertise in that area would be critical to ensure we were getting what we needed, whether it was rebates or, our formulary being what it should be to cover the needs of all of our residents, including the members on PEB. So there's a lot of moving parts. I mean, obviously, I'm open to those discussions. That's not something PEB can do on its own. We're not big enough for one. And for two, we don't have the expertise or the resources within our agency to take that on. But we would be happy to work with any organization that can provide some good ideas in that area.
And just a follow-up, who is the PBM that we use for those three plans?
This is Celestina Glover for the record. This Express Scripts, we refer to them as ESI. They are PBM. They have been our PBM for several years. We are due to go out to bid again. I believe we're going out in this summer or the early fall, as that contract expires June of 2026.
Has there ever been any discussion with Express Scripts as to what the magnitude of the rebates that they receive from the drug companies based on the prescriptions that are dispensed here in the state of Nevada?
This is Celestina Glover for the record. So we build into our contracts that we are to get the maximum, actually the full rebate. We also have our consultants go in and do a market check annually, and they review what the rebates are for the various drugs that qualify for those rebates. And then our contracts are amended to adjust for any increases due to us. In addition to that, we have an independent auditor go in and audit the PBM to see if, one, they're paying claims correctly, but two, are they passing on all the rebates that they are supposed to pass on to PEB? And that happens every single year. So we believe we're getting the maximum rebate. I know we're probably getting rebates that maybe ESI doesn't always agree with, but per the terms of the contract, they do pay what is required in that contract. And we do have two different checks in place, two different vendors that go in and look at that to make sure we are getting what we're supposed to get.
Thank you very much, Senator Stone. Assemblyman Carter.
Thank you. Yes, ma'am, I appreciate your report, and I'm going to ask for a little indulgence. I've got extensive experience in the Taft-Hartley world. I know this is different than Taft-Hartley, so if I take and go down a wrong road, please don't hesitate to correct me. The first question I had was, do we have stop loss on our self-insured plans, and what is if we do, what is the attachment point?
This is Celestina Glover for the record. We don't have stop loss insurance in place on our plans. We do have three different reserve categories that are what we refer to as restricted reserves. So we have the IBNR, which is incurred but not realized or reported. It's called both things. Those are for claims that have happened in a previous year that get paid in a subsequent year, or should the plan close down tomorrow, we would use that funding in addition to whatever we have in our budget to pay the run-out claims. We have a catastrophic reserve in place. That reserve is for rate stabilization and for catastrophic claims. So those big claims we weren't expecting that we didn't account for in our operating budget. If we need to tap into those funds, we go there. We have a health reimbursement arrangement for our members, and those balances roll over year. We keep a reserve to cover approximately 75 to 80% of whatever those balances are each year. And that reserve is used for exactly that. If for some reason, everybody was to file a claim on their HRA, we would have sufficient funding to cover 75 to 80% of those claims from the reserve, plus what we have in our budget to pay for routine claims that we expect to see month over month, year over year. So that is what we use in place of that stop loss insurance.
Thank you. And with the chair's indulgence, I got two more. We heard it brought up concerns about losing the HMO and impacting mental health benefits. We see that mental health benefits are very important to our population. How are mental health benefits? Why are we hearing that there's a lack of providers or lack of access through the self-insured plans?
This is Celestina Glover for the record. The self-insured plans have access to, in a lot of cases, the same providers that the HMO has access to. It depends on the region, city, town, state, that those providers are in and that our members are in that need that care. We also have telehealth, so a lot of those counseling visits can be done virtually if the provider and the member are not in the same location. Part of our analysis that will be discussed during the January board meeting, that meeting's January 23rd, is to look at disruption. My understanding is that for the most part, the majority of our providers that are on the HMO plan contract with other networks, including our network through UMR. So those providers are accessible by both the HMO members and the self-funded plan members. I think, individuals know that they can get to Dr. Jones in this plan, and they don't always know that Dr. Jones can also be accessed from another plan, that they're not exclusive to one organization. So I think in some cases there's a misunderstanding. That doesn't mean there aren't providers out there that are not contracted with our network, and whenever we see that, we have our network try, and they do it on their own, whether we ask or not, to work with the various providers out there to get them contracted within the network so our members have access to all the providers possible.
And one last one. And I'm not second guessing your board. I'm sure that your board is very, very talented and has a breadth of knowledge. Just out of curiosity, has the board ever explored on-site or near-site primary care clinics as a way to boost quality of primary care and contain costs?
This is Celestina Glover for the record. We did explore that several years ago, actually before I retired the first time, so 2016, 2017, I would say. At the time, the concern was the cost of getting a near-site clinic stood up. And then, at least in the north, a bigger concern has been raised or was raised at the time that clinic would be exclusive to PEB members and that other residents wouldn't have access to those providers that were within that clinic. We don't know if financially we can actually stand up a clinic and everything that goes with it. That is something we briefly talked about recently, but we haven't done any more in-depth studies. I think, again, it's how spread out our members are. Is a clinic in Carson? Is it down in Vegas? Is it in Elko? Is it in Reno? And who has access? So if it's in Carson, it may benefit Carson City members, but it's too far for the Elko members to travel to, and maybe the Reno members don't want to come to Carson. So how we set that up with how geographically spread out we are, that becomes the difficulty in determining if that is the best way to look at providing benefits to our members. In addition to that, as you've said, and many other folks have said too, that we have a shortage of providers in general. Where are we going to find those providers that are willing to come to this clinic? And if we could figure that out, maybe that is a direction we could go in. That is something we can explore, but at this point, it has been explored in the past. It's been a lot of years since that happened, but at the time, it was determined not to really be a viable option. That doesn't mean it isn't a viable option at a future point in time.
Thank you.
Thank you very much. And I'm going to jump in here because I have a couple questions. One of them is all of the self-funded plans are in the same risk pool. So does it matter if the sicker members are on a different plan from the healthier members?
This is Celestina Glover for the record. For the self-funded plans, it doesn't matter as much. It does matter for the HMO because they are not rated in the pool with the self-funded members. So that continues to make the HMO potentially more and more expensive, and no way for us to offset those costs other than to pay the higher premium unless HPN wants to, give us a lower rate just 'cause. For lack of a better term. I think where I look at it, it's not just the rating pool itself, it's how can we best use our dollars to provide the best package of benefits to all of our members, not just those in one plan or the other as far as a self-funded versus a fully insured plan. And as I said, the HMO plan also has a profit margin built in because obviously they have their overhead, where PEB's overhead is essentially 1.5% to 2%, and that is not seen in the industry, generally speaking.
Thank you very much. And another question that I had was, the employer subsidy is the same for all the plans. So how does the PMPM increase for the HMO and the EPO? How does that impact that?
This is Celestina Glover for the record. So the PMPM is the cost of those claims. So we take, if we have, $10 in claims and we have 10 members, it's $1 PMPM. But that doesn't mean all 10 members are accessing care. That could be one person who costs $10. So that is where the PMPM comes in. The amount of the subsidy, so the Aegis and Reggie funds that pay in, the more that the state pays into those funds, the more we can offset the amount that the members themselves have to pay. If that subsidy goes down, but the rates go up, the difference comes out of the member's pocket, regardless of what the claims look like. The rates are determined by what our claims cost, pharmacy, medical, and dental, what that actually is. It also considers life insurance premiums, administrative fees that we pay to vendors to assist us with the plan, as well as our operating costs, which is payroll, buying paper for our copiers, things of that nature. So the PMPM looks at kind of a combination of things, but what I've reported here is really what the claims costs themselves are.
Okay, thank you very much for that information. And then I have one last concern that was brought to me. Someone contacted me and told me that the Carson Tahoe Hospital was going to change taking our PEB our PEB insurance participants. And they said that the reason that was going to happen is because they weren't getting paid timely. I don't know if that's true or false. I was just wondering because we have a lot of state workers in Carson City. And so for them to have to go into Reno to a hospital can be a real hardship. So I was wondering if that was actually going to happen, if that was hearsay, if you can just shed some light on that, please.
This is Celestina Glover for the record. Yes, we're in talks with Carson Tahoe. They have opted not to renew their contract with the United Healthcare Network. They have cited some various reasons for making that decision. Ultimately, it's a business decision on their part. We have the same concerns with our members in the Carson area, and it's not just Carson City residents. It's Reno residents who happen to work in Carson and access providers in Carson City or any of the surrounding areas to Carson City, because so many of our folks do work in Carson proper. We have asked our consultants to begin drafting an RFP, which they are doing. We're planning on releasing an RFP hopefully early February, but it looks like it'll be closer to later in February, to have a second network that includes Carson Tahoe as part of their provider offering. That is going to be a requirement, because if they don't have Carson Tahoe, there's no point contracting with them, because that is the only reason we're going for a second network. We have asked Carson Tahoe, so their contract right now expires on May 30th of 2025. We've asked them, and the board has asked them, to consider extending their contract to allow us time to get through the RFP process. The RFP process, the way we're situated now, not only do we have to get the RFP on the streets, there's an amount of time it needs to be out there so we can get responses. We have to bring the results of the bids back to the board in a closed session. So the timing of that could mean we don't see BOE until April or May, if everything goes smoothly. The requirement right now of the board looking at these RFP results in the middle actually can extend our timeline anywhere from 2 to 4 months. So that's a consideration. We also have an implementation timeline that we need, typically about 6 months, because we need to make sure that that network, one, can get can share files with our enrollment eligibility system and can work with our TPA to ensure that claims get paid. And so we are working through that process right now, because we are trying to do everything we can to avoid this issue. We've been talking to Carson Tahoe for months, as well as representatives from UMR on the network side, to try to come to some agreement for them to resolve their issues. But it appears at this point that Carson Tahoe is not interested in extending, continuing business, although they have said that they would look at extending the existing contract to allow us time to complete the RFP process.
Okay, thank you for that information. Yes, it's a big concern, and I understand you're working towards that. And you're right, it isn't just Carson City. It's also Minden, or wherever people live that they are closest to, Carson Tahoe, that they may need those services. So I appreciate you working on that. Hopefully the RFP might solve some of that, but I appreciate that. I believe we have another question from Senator Orenshaw up north. Senator?
Thank you very much, Chair Dondera Loop. And with your indulgence, I wonder if I could follow up on something that you asked, that Assemblyman Carter asked. I'll try to be brief.
Please, go ahead.
Thank you. Just to follow up on Chair Dondera Loop's question regarding Carson Tahoe Hospital and the network administrator. Could the PEB board meet earlier, post a meeting, and just try to see if that RFP could happen earlier rather than wait 2 to 4 months?
This is Celestina Glover for the record. So the RFP is being written right now, and like I said, we're hoping to have it out there for vendors to bid on early February, but like I said, it may be closer to the end of February, because it does take time to write that RFP. We are trying to, as much as possible, reduce the timeline for how long it's on the streets, how long the analysis gets done, all of that, because there's going to be a cost to pay that vendor to get that network so that we can lease that network. We can request a special meeting. The concern is with session coming up, a lot of our members, board members, and PEB staff are going to be busy with the legislature, so trying to find time to get a quorum so that we can get them meeting earlier on. It tends to be an issue, especially with the upcoming session, but we will do everything we can to get that meeting sooner. or to get the RFP ready for their review sooner, whatever we need to do to get that done.
I appreciate that very much, and thank you. Certainly because I guess, folks here in this part of the country can't go to Carson, Tahoe, then I guess their options are go down to Douglas County or up to Reno, and certainly that presents extra obstacles to them. Like the chair, I've also been contacted by some members who voiced a concern, and I don't know if it's valid or not, but I wanted to ask that members in the PPO plan have had trouble with behavioral health care, that some of the behavioral health care providers have had problems with their payments from the network administrator, and that they've left that network. Is that something you believe is true or know about, or wonder if you could give us some information about that?
This is Celestina Glover for the record. We've heard similar concerns, but when we actually look at the information we're provided, for the most part, I think I've heard of one actually leaving the network, but we haven't seen a mass exodus. Oftentimes what we're finding is that there's a combination of issues with the payments. Either it's documentation that the TPA requires, that's the third-party administrator, requires in order to pay the claim. Are they submitting that paperwork correctly? And then early on with the TPA that we have currently, there were some definite growing pains. This was before I came back to PEB. But since then, they have improved their processes to get those payments out more timely. So I think a lot of the issues have been resolved. That doesn't mean there aren't problems once in a while, but as soon as we hear about them, obviously we try to address them as quickly as possible so we can get those resolved.
Thank you. And then to follow up on one of Assemblyman Carter's questions regarding the HMO plan, you mentioned earlier when I asked you that you felt it's getting to a point of unsustainability. And if that plan ends up being eliminated, the concern that's been brought to me is that members feel that there are predictable costs and they're worried about losing their providers. Do you feel that they'll be able to find those same providers in the other plans if the HMO plan is no longer an option and they'll still have that predictability in the costs?
This is Celestina Glover for the record. Yes, part of the analysis is a disruption analysis to determine how many providers are not in the existing network for people to access. So we're looking at that number, and we're also looking at the restructuring of the low deductible plan to make that payment structure the cost for provider care. So if you're going to, your GP for a general visit, those are pretty similar already. So we're looking at just restructuring, getting the co-insurance, which is a % of the cost, to an actual flat rate. So we are trying to get that set up so that they have a level of confidence, those members have a level of confidence that they're going to know what their out-of-pocket costs are when they go for a visit.
I appreciate that. And on that disruption analysis, is there any data now as to if the HMO plan is done away with, members will be able to stay with their providers if they migrate to the other plans? What providers are, on the other plans as well?
This is Celestina Glover for the record. That'll be part of that disruption analysis that says how many of those providers won't be there, and we'll be looking at how many claims we see from our members. On an individual member level, not on an individual claim basis, because one member could have 20 claims, obviously, to see how many people really are going to be affected by the potential of certain providers not being in the network. I will say that based on the structure of United Healthcare, our TPA, which is UMR, and the HPN, the network information, the providers tend to be on both networks. So it's not the same as it was in past years, where it was definitely a totally separate. If the HMO was out, we lost the entire network. That's not the case today as it was maybe 5 or 10 years ago.
Thank you. And that disruption analysis is not done yet. That's something that...
Correct. That will be presented at the January board meeting.
Thank you. Assemblyman Carter asked about mandatory reserves, and you answered his question, and I just had a follow-up on that. Where is PEB now in terms of mandatory reserves? Do you feel they're adequate? Do you think that they need to be bolstered?
This is Celestina Glover for the record. Currently in the current plan year, we did have to reduce those reserve levels because the beginning cash, which supports the reserves, was lower than budgeted. But we have included the replenishment of those reserves in the upcoming legislative session. And so for the upcoming biennium, we'll be back to the level that we believe we require, and we believe that's sufficient, barring no major changes to what PEB looks like today versus what it looks like a couple of years from now, that it should be sufficient.
Thank you very much, Ms. Glover. And Chair, this will be my final question. I appreciate your indulgence. Do you foresee any substantial rate increases to members over the next biennium?
I do foresee, this is Celestina Glover for the record, I do foresee rate increases across the board on all the plans, just based on what I'm seeing in our claims costs right now. How high those rate increases are, I don't know. Again, we've included some assumptions in our budget submission to account for what we're experiencing and what providers in general, or providers of healthcare plans, are seeing in general. So all of that is taken into consideration and has been built into our budget.
And but what those rate increases are, that's not something right now you can comment on. Okay, thank you. Thank you, Chair, for the indulgence.
Thank you very much. All right, I think we are out of questions. Unless anybody raises their hand. If you raise your hand, I'm going to charge you. Okay, thank you. Ms. Glover, thank you very much. I believe we might be on section 4, number 4. But if I'm wrong, just keep going wherever you are.
This is Celestina Glover for the record. So we are on number 3 in my slide presentation. And essentially, this is the communications to our members. And there is a schedule included in your packet. The schedule only reflects the events that we've had so far in the year and what's been scheduled through the end of December. Pretty much every month we have some sort of communication to our members, either through a training event, whether it's for our agency representatives or HRA discussions for our Medicare exchange. We have a quarterly newsletter that goes out, and then anytime there's a major change that we feel like we need to get out to the members ahead of time in between all these various sessions and the newsletter, then we'll put out additional communication at the board meetings. When there are things coming up, I will include that in my executive officer report as a reminder to members that something's come up, like the Medicare exchange, Medicare open enrollment was going on in between October and early part of December, so that information comes out continually. The slide on the screen.
Ms. Glover, if I could interrupt you, I'm sorry.
Yes.
For members in our packet, in our book, it is 4.4. So I just wanted to make sure if they wanted to follow along, it is 4 for us. Don't worry about your slides. We are just on number 4 with the information. Thank you.
Thank you. And I believe, this is Celestina Glover for the record, I believe it's on page 223 of the packet, give or take.
Correct. You are correct.
So the next section is our audited financial statements. What you're going to see in the packet, and it is actually on page 37, it's early in the packet, is our most recent audit that was completed. This audit was presented to the PEB board in July of this past year of 2024. Ide Bailey is our auditor, and they're in the process now of scheduling the work to be done They originally thought they would begin field work in January, but now that has been pushed into March. Part of that is because we require certain data to come from the state controller's office, and with the new ERP system and everything that's been going on over the last couple of years, they're not ready to complete their entries, so our auditors are going to delay their field work. But as soon as all the data is available, we'll get that scheduled, and we'll present, hopefully, those financial statements in July of 2025 to the board meeting at that time. It may be as late as September, depending on when the financial statements can be completed. The next section is other post-employment benefits, or OPEB, as it is referred to. Other post-employment benefits are retiree benefits other than pension, so in our case, health care. The evaluation is required to be done, a full evaluation, every 2 years. The in-between years can be a rollover. And the one that is in your packet, which I believe is on page 231, is a rollover that is for June 30th, 2023, as reported on June 30th of 2024. The OPEB valuations are included as a disclosure in our annual financial statements. It estimates our total OPEB liability, which is the present value of benefits for current employees and retirees. What is considered in this is assumptions about demographics, turnover, mortality, disability, retirement, healthcare trends, and other actuarial assumptions, and it is attributable to the past service of those employees and retirees. The PEB plan has opted for a pay-as-you-go option. This is pretty typical with most government plans. And then, like other states, PEB has taken steps, the state of Nevada has taken steps to reduce the liability. And part of that, which has been presented in previous IRBC meetings, is that those retirees, those employees that begin employment after December 31st, 2011, when they become retirees, they will be able to opt to join the PEB plan, but they will not receive any subsidy. They would be required to pay the full amount for that plan, which, looking at it, those plans are very expensive. So I don't know how that will work for those individuals. But a change to that would greatly increase our OPEB liability, so there's been a reluctance to change that rule, and so that is where we're left. And then final on my presentation, this year we had the biennial compliance report. That report begins on page 294. NRS 287 requires an independent biennial review to determine whether we're compliant with state and federal law. This particular review, as I said, just finished. It was presented to the PEB board at the November board meeting, and it considered the documents that were in effect for the current plan year 25, which is July 1st, 2024 to June 30th of 2025. It was determined that for the most part, PEB does cover all required benefits, but what we need to do is really look at our documentation to essentially clarify what we've written. Sometimes it's not clear in the documents. There are a lot of master plan documents for the various plans, along with a host of other documents that we provide to members. They're on our website, but oftentimes when you read those documents, it's not real clear what we're saying you can and can't do within the plan. None of the findings were unexpected, as rule changes at both the federal and state level are consistently changing, so it would be amazing if we could get ahead of them, but we would have to know what they were going to do before they did it. So we comply as soon as we're made aware. During our legislative sessions, obviously, we follow the BDRs that have been presented in any bill discussions. And then we also look at what is happening at the federal level to ensure that we are following all of the laws put in place and that we are providing the services we should be providing. You will note that there are no comments in the column for PEB responses. We are looking at that and prioritizing which things we need to address first. And then we will present that back to our consultant that did the biennial review, and we'll look at that. We're going to concentrate on notices in our documentation first, and then we'll touch everything else after that. And with that, I'll take any other questions.
So you sort of covered this, but would you just confirm that the plan administrator, UMR, is administering the benefits in accordance with the various amendments to NRS 287.04335 that were approved in the 2023 session?
This is Celestina Glover for the record. Yes, they are administering that, and we did update our plan documents to show what our benefits should look like and what we're required to cover to make sure we didn't miss anything. In addition, UMR has a quarterly audit, so the auditors, our independent auditors, go in and make sure they are in compliance with whatever federal and state law is and whatever our plan design says, because we may be covering things that are not necessarily required by law, but we offer it as a benefit option, and they're making sure that those claims are paid according to what is approved in our benefit structure and per state and federal law.
Okay, thank you very much. Unless anyone on the committee has another question, Ms. Glover is done with her part of the agenda. Thank you very much for joining us here today. Thank you for answering our questions. And thank
Madam
you
Chair.
for...
Madam Chair.
Yes, sir.
Assemblyman Gurr, I have a question. Well, I'm not sure it's a question, it's a comment more than anything. Before they leave, I've heard conversations about provider problems inside of the eastern part or western part of the state, somewhat in the southern. I haven't heard anything, nor did I see anything in these documents about anything in the eastern part of the state. And if they're having any problems with providers there or how the retirement system's working. And one or two things are happening. Either it's working perfectly because I've never heard a word, or it doesn't work at all, one or the other. And I've not seen it addressed. So if you could, talk about the eastern part of the state and the providers and what's going on there.
This is Celestina Glover for the record. I have not been given any specific information about problems with providers in the eastern part of the state any more than any of the rest of the state. And it typically revolves around provider availability. We have a shortage of providers statewide. We have a shortage of providers nationwide, and the eastern part of the state is having similar issues. Obviously, if you're in a rural part of the state, it's harder because we don't have providers in some of those smaller communities, and it does require members to travel. We do provide travel benefits to our members to allow them to get to providers when they have to come into Reno or Carson or go to Las Vegas or go out of state. So we do try to work with those individuals. Having a provider in a small location like a Tonopah or in Austin, although we may have members out there, it is very difficult to convince a doctor or a nurse or whoever to actually go out to those communities and live and provide those services. So it does require a lot of times for those individuals to have to travel.
Thank you. I pretty much understand that, but I'm impressed that you let them go out of state, because that's a whole lot of what happens in the eastern part of the state, Salt Lake City.
This is Celestina Glover for the record. We know that happens in the east and the west. If you're in a border town, so to speak, or within a couple of hours of the border, that is an option. We do have a Centers of Excellence contract, and that may send our members to Arizona, to Utah, wherever the best facility is for the type of care that member needs. And we pay for those claims and provide the travel for the member and one companion to go with them, so that, you know, they have someone with them with those, to help them with navigate the situation. So that is something that is covered in our plans, always has been covered, at least for as long as I've been around with the plan. I've been with the plan since 2012, as far as working for PEB.
So my assumption that nothing's really wrong with it because nobody complains is pretty much right on. One other specific question, is the Northeastern Nevada Regional Hospital a provider? Or do you know?
This is Celestina Glover for the record. I'd have to go back and double check, but I believe they are in network. For the most part, most of our facilities are in network. We do have to sometimes do special agreements with those facilities if there's a service there that they provide and they are an out-of-network. So we will then try to do one-off agreements as necessary, so that our members can get the care they require.
Thank you, I appreciate it. Thank you, Chair.
Thank you very much, and thank you for that information. Thank you for joining us today. And we will take just a 2-minute recess and let PERS get ready for their presentations and switch some staff around. Thank you. Okay, I think everybody's ready and in place. And members, we will start with agenda item 5, and we'll go to number 1 first. So please go ahead when you are ready.
Good morning, Madam Chair, members of the committee. I'm Tina Liss. I'm the Executive Officer of the Public Employees Retirement System. Also testifying today on later agenda items will be Steve Edmondson, our Chief Investment Officer, and Kabrina Fazer, our Operations Officer. Item 5.1, beginning on page 389 of your packet, is an update on the fiscal year 2024 actuarial evaluation for the Public Employees Retirement System. Actuarial evaluations determine the projected liabilities of the plan and the contribution rates needed to fund the system on an actuarial reserve basis. Several areas are analyzed during the course of the evaluation, including the plan design, the member demographics, and economic assumptions. Pursuant to the Nevada Constitution, the Retirement Board must adopt the actuarial assumptions that are recommended to it by the independent actuary that is hired by the board. And then by statute, the contribution rates are set based on the actuarial rates developed by the actuary. The contribution rates must change with the first full reporting period on or after July 1st of each odd numbered year as determined by the even years valuation. So this year, so the 2024 valuation does affect contribution rates. The ultimate cost of the benefits paid by the system are determined by the plan design, which is set by the legislature, and future events such as the length of service, average compensation, and longevity of our members. The goal of actuarial funding is to ensure that the current and future benefits are paid for through appropriate level of employer and employee contributions and the investment earnings on those contributions. To project liabilities of the system and to determine these contribution levels, assumptions are made about future events that may affect the amount and timing of benefits to be paid and the assets to be accumulated. As part of this valuation process, actual experience is compared against the projected experience, and any deviations are recognized as gains or losses in that year's experience. The use of appropriate assumptions is important in maintaining the adequate funding, and things do change over time. Demographics change over time, economics change over time. And so every 4 to 6 years, the board does an experience study to make sure that the assumptions are keeping in place with the actual experience. As you may recall, the last experience study was in 2021. The assumption changes that were required as a result of the recommendations of the independent actuary caused significant increases to the contribution rates for both the regular and the police fire fund. Because of that, the actuary had recommended a 4-year phase-in process of the rate changes solely attributable to the assumption changes, not attributable to other experience. And this is the last year of the phase-in of those rate changes from the 2021 experience study. So the contribution rate changes in this valuation have been expected since 2021. The charts on page 393 and 394 show the changes to active members in the regular and police fire fund. This valuation shows an overall increase in active members to 112,019 members from 112,019 members to 115,765 overall. We saw an increase of 3.2% in active membership for the regular fund and 4.4% for the police fire fund. The charts on pages 395 and 396 contain information on the retiree membership and the average benefit amounts. On pages 397 and 398, you will see the actuarially calculated contribution rates for 2024. These rates reflect both our asset smoothing process, which is a mechanism in which gains and losses from the investments are smoothed in over a 5-year period to help reduce the volatility of the investment markets. And it also, again, reflects the last year of the phase-in of the contribution rate changes. The actuarial rate for the regular fund came in at 36.75% compared to the current statutory rate of 33.5%. The actuarial rate for the police fire employer pay plan was 58.65% compared to the current statutory rate of 50%. The results are similar in the employee-employer pay plan. And as this is a rate setting year, the statute would require the rates to go up in accordance with these rates. And just as a reminder, even though we call the contribution plan the employer pay plan, this rate is shared equally between the employer and the employee, regardless of the plan that they are on or the employer that they have. Under the applicable statute, the employee's share is paid either through a reduction of pay or in lieu of an equivalent pay increase. That is, if the employee had been previously promised a pay increase, then in lieu of getting that increase, it would go towards the increase in the contribution rate. Another thing I might want to mention also is the state is currently a little bit under 20% of the active membership of our plan. Clark County School District is our largest employer at close to 30% of the plan, and then the state is the second largest. Now the chart on page 399 shows the change in the actually determined rates broken into categories to show the causes of the actual rate increases and decreases. The rates shown are the average for the employer pay and the employee-employer pay, so they don't exactly match up with either, but this is just to illustrate why the rates are changing. And the changes are shown over a 2-year period rather than a 1-year period to have a true comparison with the current statutory rate. The system recognized a gain in investments in this valuation due to a very strong investment year and also to our policy of smoothing, where we had some previous gains that we're smoothing in still, as well as one loss. And due to this, the system has approximately $2.1 billion in unrecognized gains that will be recognized over the next 4 years with future years investment gains and losses. And because of the volatility of investment markets year to year, asset smoothing in this manner is important for predictability and is a standard practice throughout the public pension industry. For the regular fund, the investment gains, the changes in normal costs, and the effects of amortizing the unfunded liability over a larger than expected payroll had decreasing effects on the rate. These decreases were offset by increases due to losses in contribution, individual salary increases, and the final year of the phase-in. And it's important to note that the actuarial rate increased in an amount less than the phase-in rate, which means that other than the phase-in rate, or if he had not been phasing in that prior contribution rate increase, the actual rate would have decreased somewhat in the regular fund. The increase to the contribution rate in the police fire fund has similar causes, but it's more magnified. There was a significant difference in the experience on the police fire side that caused the contribution rate change to be more than the final phase-in amount. Certain experience may have greater impact on the police fire fund due to the smaller size of the fund and differing demographics and benefit provisions. Other than the effect on the contribution rate of the assumption changes, the most significant factor in the contribution rate increase in this fund was that the increases to the liability based on individual salary increases, that is the higher member's salary, or if it increases more than we expect, that creates a higher benefit, which creates higher liabilities. Those increases were not fully offset by other gains as they were in the regular fund. Now, the main distinguishing factor between the police fire fund and the regular fund is that the police fire fund has earlier retirement provisions. And with our post-2015 members, they also have a higher benefit accrual rate than the regular fund. However, the mortality table for the two groups is very similar, not significantly different, which means that the benefits are paid longer out of the police fire fund, which also impacts the differences in the contribution rate. We pay the benefit longer, it's a higher liability because of that. And we also have a shorter time that we're collecting contributions for that. Now, based on the 2024 valuation, the amortization period, the time in which the current unfunded liability will be paid is 14.9 years from June 30, 2024 for the regular fund and 18.2 years for the police fire fund for an aggregate of 15.7. Page 400 shows information on the actuarial funded ratio of the system. This is based on the actuarial value of assets. The actuarial funded ratio for the regular fund increased from 75.5 to 75.8%, while the police fire actuarial funded ratio decreased from 75.2 to 75.0. The combined actuarial funded ratio increased to 75.6, and on a market value, the combined, that is the regular and the police fire combined, increased from 76.2 to 78.1%. That's all my prepared remarks on the PERS actuarial valuation. I'd be happy to answer any questions.
Thank you very much. And we'll go up north. Any questions up north?
Chair, may I have a brief question?
Please.
Thank you. Thank you very much for the presentation. Sometimes we hear a lot about unfunded liabilities and, is PERS solvent, and I appreciate all the data you've given us. I just wonder if you could speak to that, just unfunded liability, solvency of the system.
Sure, this is Tina List for the record. So the unfunded liability is a comparison of the assets on hand currently to the liabilities that we project will be paid out over time. So the liability itself is paid out over the next 10, 20, 30, 40, 50, 60, maybe even 70 years, because if someone enters at, say, age 20, they may be receiving benefits until they're 90, even 100. So that liability calculation is what we anticipate we will pay into the future for all current and retired members, so active members and retirees. So the liability itself that you're looking at is not something that is due today, nor could it be paid today, because it's not due until each month of a member's retirement, which can be very far off into the future. It is a number that we look at as one measure of a public pension system's health, but it certainly is not the only one, and trends need to be evaluated as well. We do not have big swings in our funded ratio, which also shows the stability in that we don't have large swings up or down with, say, investment markets or certain demographic events. But I will say that the 2021 experience study strengthened greatly our assumptions, made them more conservative, and so it's put us in a much better position going forward. And it did so in a way that really didn't affect the funded ratio a great deal. And also, as you will see, the funded ratio goes up a little bit when you take our market value of assets. So given the strengthening of the assumptions and where the investments are at this point, I think the board's very happy with where the funded ratio is. And we certainly, from a solvency perspective, are in no danger of not having the money on hand to pay benefits as they come due.
Thank you very much for the answer and for all your hard work there at the system. Thank you, Chair.
Thank you very much. And I have a question sort of along the same line. So what are the primary factors that contributed to the proposed increases in the contribution rates?
So as in the regular fund, it completely due to assumption changes in 2021, which changed the mortality tables to reflect actual experience. And keeping in mind that the liability is based on the assumptions that we have. And the liability number is not going to be very accurate often to the future if your assumptions aren't matching your experience. So those assumptions were changed to max our experience to make sure that we were realistically following the changes in what our membership is doing and the demographics. So ultimately, you need to go back to the assumption changes to understand most of the rate increase, and that has to do with changes in mortality tables. People are living longer. We have compounding COLAs every year after the third full year in retirement, which means that the liability increases quite a bit when people are living longer and drawing their benefits longer. That, I think, was the main factor. The other factor was the change to the payroll growth assumption. We had for decades had very high payroll growth. High payroll growth leads to higher contributions. And then 2009 forward, we had very low payroll growth, sometimes negative payroll growth. So that was another assumption that was changed that is contributing to the changes in the contribution rate. And on the police fire side, the salary increases seen over the last 2 years have changed the liability enough to impact the contribution rate. It was somewhat on the regular side, but not to the same extent as the police fire side. And unfortunately, the police fire side is it's a smaller fund and it is more subject to volatility.
Thank you. And so were there any other options that were contemplated or discussed to offset those increases in contribution rates, and why were those options, if that was discussed, why were those options, were they not considered? Can you talk about that a little bit?
Sure, Tina List for the record. So as far as the assumptions themselves, by constitution, the board is constrained to adopt the actuarial assumptions recommended by the independent actuary. The board does not have discretion there. And nor should they, because if you're funding on unrealistic assumptions, you're not really funding. So the assumptions have to be realistic to make sure that you're funding and the benefits that our members have earned will be paid. So in 2022, when these rate increases were first, kind of the magnitude were first shown, the board did some work on the amortization period. They made a change to the amortization period for the police fire fund that did help with the rate increases. The rate increase would have been a little bit higher than it is now had the board not changed the funding period to 20 years for the police fire fund. That's why you see the difference between the regular and the police fire. The 20 years is about as long as you want to go on your unfunded, on your amortization for your unfunded payments, because otherwise you get into negative amortization, which means that you're not even paying the interest. So that was one thing that the board did. As far as the legislature, if you will recall, because of the employees paying half, there was some work done. A number of options were looked at, and a bill ultimately passed that did not go into effect. Otherwise, and the board has looked at other options as well, but as far as what the actuary will recommend, there really is nothing but to make sure that we are recognizing the full costs. And I will also mention, of course, that the board is in control under Constitution of the assumptions themselves. The legislature is in control of the plan design and the contribution rate mechanism.
Thank you. Any additional questions from any of the members? Assemblyman Carter.
Good afternoon or good morning, and thank you for the report. And I had a few questions. The first one is pretty obvious, but are all of the plan design changes that have been put in place, are they accurately provided to the actuary that's doing these calculations? So all of the benefit cuts, benefit increases, all of that?
Yes, Tina List for the record. Yes, so each year the actuary looks at all the benefit provisions and then takes into account any changes. You will have seen that over the last, probably 5, 6, 7 years, I don't know how far back, the normal cost itself of the benefits has been decreasing slightly, other than for the police fire fund this year. And that is due to mostly because of the new tiers. But as you're aware, the legislature changes for new hires only, in accordance with case law in the state of Nevada. And it takes a long time for changes, for the results to be seen from those changes, because when you're only applying them to new hires, the money savings on the benefits is well out into the future.
Thank you. So you said that we were looking at a 20-year amortization period, and I see that we're looking at the current rates bring it to 18 point something or other. Why didn't we push that as far as we could to try to ameliorate these pretty drastic contribution increases?
Tina, for the record, so the board did do that in 2022. So that's why let me back up. Each year's gains and losses amortize over a 20-year period, and it counts down. So we have layers at 20 years, 19 years, 18 years, 17 years, potentially, because you're giving that piece its own 20-year period. So each year's piece gets a 20-year period to be paid off. And so in 2022, there were some layers in the police fire fund that I think that had gotten down to, say, 15 years, 14 years to when they would be paid off. And to help with the contribution rate increase, the board put those all back together and put them on a 20-year schedule. And so that layer is at 18 years itself. The current year is at 20 years. So because that's already been done in the police fire fund, moving the entire thing to 20 years wouldn't do much to help with the rate increase now. That work's already been done. And if you'll notice on the regular side, it has a average time period about 14 years because its biggest layer was not redone to 20 years in 2022. So for instance, the big layer, I believe, has 10 years left on it. So in the regular fund, once that big layer of 10 years gets paid off, assuming it doesn't get rolled back out, then that rate will go down. So if we continually put it back out to 20 years, it will never get paid off. And so I think that's why the board would, we certainly don't want to continue doing that. But that was something I think just with an extraordinary rate increase due to the assumption changes. But again, since we're only at 18 with the police fire, moving it back out to 20, I don't think would have a lot of effect on this rate change.
Thank you. And so for clarification, again, I got a disclaimer. I've got a lot of experience in ERISA plans. And in those plans, they try to stay at that point, that payoff point, 80% funded or whatever, to where we just keep pushing that mortgage out Why are we trying to pay off? I realize that there was a industry change a decade or so ago to go from pay-as-you-go plans to buying down or moderating the unfunded liability. But are we too aggressively moderating the unfunded liability? And shouldn't we, could you discuss why we don't keep that mortgage, so to speak, at 20 years?
TLS for the record, because then it would never be paid off, right? So
But
you'd be carrying it continually. I'm sorry, excuse me.
No, I apologize. Then I don't understand that, because we're supposed to be working on the full faith and credit of the state of Nevada. State of Nevada is not going to disappear. So the idea of paying it off really is not how pension funds are supposed to work. There is supposed to be an ongoing unfunded liability. And why are we dealing with this type of mentality rather than the industry standard of keeping it at a certain funded ratio?
Tina List for the record, keeping it at a certain funded ratio. So our goal is 100% funded to make sure that the benefits can be paid. And I will agree that the state of Nevada is considered an ongoing concern, unlike a private business where you might consider them to go out of business. You know, for instance, a private sector pension plan has different accounting rules to take care of the eventuality that they could, say, go out of business, and then the pension would go out with it. So yes, I agree that it is an ongoing. We do intend that the state will be ongoing into perpetuity, hopefully. But as far as standards in the public pension world, that would be considered an open amortization period, which would require disclosures in the financial statements, because an open period is not within certain standards. I also believe it would affect the state's bond rating if we were not making progress towards making the unfunded payments and paying off certain layers. And so that would be kind of the answers to that, and just to make sure that we have the money on hand to pay the benefits.
Thank you for that. I'm still very confused and going to have to dig in more about why we have a goal of 100% funded when in the standard defined benefits world that typically, well, before Pension Protection Act, it was 65% funded and then you were in trouble. And now it's been boosted up artificially, unfortunately, by that act to 80 to 85% funded in perpetuity. You mentioned that salary increases are part of the impact on this. Aren't salary increases, because this is a percentage, isn't that built into the system? As salaries go up, contribution rates go up because it's figured as a percentage rather than a hard dollar number.
TLS for the record, yes. So there are two impacts on the salary increases. There's the impact it has to the benefits that we pay, so to the liability, and also, as you say, the percentage of payroll, so the contributions that we get in. So there is a difference in the contributions that we get in and the difference to the liability depending on how you're getting more payroll. For instance, whether you're bringing in a whole lot of new members or you're just having the same members, but they're getting paid more. So, but yes, there is some offsetting effects to the increases. So you have salary increases, then the liability goes up. But as you say, the contributions can also go up because it's a percentage of payroll, and that's an actuarial calculation. So the regular fund, the extra contributions, in essence, more than offset the extra liability. So the increased salary actually, as a combination, decreased contribution rates a little bit. On the police fire side, because of the demographics and because of the longer period that their benefits are paid, the salary increases the liability by more than the extra contributions coming in. That won't always be the case, but it was with the demographics in this particular year.
Thank you. And just finally, I just want to say that we're looking now, we keep talking about retention of state employees and governmental employees. And we're looking at a system that has gone from, 15 and 25% of somebody's salary going towards the pension plan to where now we're 35 to 40% and over half of the wages going into the plan. And it sounds like a lot of it was triggered by changes in the assumptions and stuff. And I just want to say, I think that we really need to look at that because, in a time when we are hearing, and I see that smoothing impacts that, but that where our state is bragging about our investment returns in our pension plans, we're a national leader in investment returns, but we're seeing those percentage increases go up. And I really think that we need to take a good, strong, hard look at how we're doing things because I don't see this as sustainable. Thank you.
Thank you very much. All right. I don't think we have any additional questions. So if you want to continue, go ahead, please.
Yes, the next agenda item, team list for the record, is item 5.2, beginning on page 401 of your packet, and that's an update for the fiscal year 2024 actuarial evaluation for the judicial retirement system. The Retirement Board by policy conducts an annual actuarial evaluation to monitor the assets and liabilities associated with the judicial retirement system. And similar to PERS, this is a rate setting year for the judicial retirement system. And the contribution rates are adjusted by statute in the same manner as PERS. The JRS covers both state judges and municipal justices, judges and justices of the peace of local jurisdictions that have opted to participate. But unlike PERS, this is not a cost sharing plan, which means that the various employers have their own actuarial contribution rate calculated, and they pay different contribution rates based on their own demographics and their membership. The actuarial contribution for the state judges, consisting of normal costs and administrative expenses, is 24.31% as of June 30, which is compared to a statutory rate of 23.25%, which will make the contribution rate for state judges change to 24.25% as of July 1st, 2025. The amortization payment for the state's unfunded liability is not included in the calculated contribution rate, but is paid by the state as an annual lump sum payment in both years of the biennium. This payment will increase to $1,716,852 for each year of the next biennium as compared to $1,551,796 in the current biennium. The ratio of actuarial value of assets to the liability increased from 92% to 94.9% on a total fund basis. And on a market value of assets, the funded ratio in aggregate is 99.6%. The unfunded liability in totality decreased from 16.2 million to 10.9 million. Pages 403 to 405 contain demographic information for the JRS, both state and non-state members. 406 contains the contribution rate for the state, and 407 and 408 contains contribution information for the local jurisdictions. You will see a large variety in the contribution rates for local jurisdiction. It's because of the small number of covered members and whether or not the jurisdictions have any retirees. Some of the jurisdictions do not have retirees yet, as this plan was created in 2001, and the locals didn't start having participation until the mid-2000s. That concludes my prepared remarks on this agenda item. I'm happy to answer any questions.
Thank you very much. And up north, any questions?
No, Chair. Thank you.
Thank you very much. All right, then we will move on.
The next, Tina list for the record, the next agenda item in 5.3 in your packet, beginning on page 409, is the valuation report for the legislator's retirement system. The provisions of the legislator's retirement system allows legislators to opt out or to terminate participation in the system. In 2024, the active membership decreased from 24 to 21 members. The number of retirees decreased from 55 to 54, while the number of overall beneficiaries decreased from 70 to 69. As this is an even year valuation, this also will affect contribution rates for the legislator's retirement system. By statute, the legislators pay 15% of their salary as the employee contribution, and the employer contribution is calculated as the total required actuarial contribution minus those employee contributions. In this valuation, the payment is decreasing from $90,579 per year to $44,584 per year. The funded ratio of the legislator's retirement system decreased from 105.5% to 104% in this valuation. Therefore, this fund is in a surplus, and we have surplus management policies with the board to manage that surplus in a little bit different manner than you do an unfunded liability. So the actuarial surplus at this point for the LRS is $202,248. And beginning on page 410 of your packet is the demographic and funding information for this system. I'd be happy to answer any questions.
Thank you very much. Any questions up north?
No, Chair, thank you.
Thank you very much. Seeing no questions down here, we'll move on. Thank you.
Yes, good morning, Madam Chair, members of the committee. My name is Steve Edmondson, Chief Investment Officer of Nevada PERS. My portion of today's report under agenda item 5.4 includes an update on the status of the investment results, which summarizes investment performance for all three funds for various time periods through the 2024 fiscal year. The first column on the left reflects returns for the year ended June 30th. It was a very strong year for investment performance during fiscal year 24. PERS portfolio generated a return of 12.0% net of fees and ended the year with just over $64 billion in assets. Over the last 40 years, the PERS portfolio has generated a return of 9.3% on average net of fees. The Legislators Fund generated a return of 14.6% during the 2024 fiscal year and ended the period with $5.5 million in assets. And the Judicial Fund produced a return during the 2024 fiscal year of 14.8% with an asset value of $208.4 million as of June 30th. The following page, page 416, I believe, titled PERS Annual Performance, details PERS investment results for each of the past 40 fiscal years. There's a horizontal line across the middle of the page, which depicts PERS long-term actuarial assumed rate of return of 7.25%. That was one of those actuarial assumptions that was changed in the during 2021 from 7.5 down to 7.25. It's always critical to remember when thinking about that return assumption, that is a long-term return assumption. Both our actual experience and expectations, we do not expect to achieve 7.25% in any individual year. In fact, we expect returns to vary widely over individual years. And our hope and our goal is to get to that 7.25% number over a long time horizon. But as we look forward, we can expect, it's wise to anticipate that over individual years, we should expect that variance or dispersion of returns to be pretty wide over single short time periods. PERS investment strategy, which is depicted on page 419, is somewhat unique in the industry in that we employ a much simpler structure. We have relative to the rest of the public pension fund industry, we have a higher allocation to high quality publicly traded U.S. stocks, international stock, developed countries only in our international stock portfolio. And also somewhat unique is that our U.S. fixed income allocation consists entirely of U.S. government treasury bonds. in addition to employing that simple structure, we deliberately avoid exposure to more complex and expensive and riskier investment approaches, such as the utilization of leverage at the total fund level and or investment strategies such as hedge funds. One of the advantages of this simple structure, I think one of the numerous advantages to our simple structure, is that our investment costs are extraordinarily low. It's something that we've spent a lot of time emphasizing with the investment programs, keeping our costs as low as possible. We want to be sure that every dollar available within the system compounds for the benefit of the members and beneficiaries rather than being paid out in investment management fees. We estimate that PERS investment costs are on average around $250 million a year lower than the median peer pension fund. If you extrapolate that cost savings out over the course of 10 years, assuming a 7.25% rate of return, that equates to more than $3 billion in savings over the course of a decade. But in addition to being low cost, this simple approach has proven to be effective over long time horizons. PERS results, investment returns have ranked in the top 5th percentile or better over the last 5, 7, and 10 years, and since inception remain in the top, so the last 4 decades, the last 40 years, remain in the top decile of large public pension plans. With that said, we certainly don't expect to be in the top of the database every year. Our experience is somewhat similar to returns relative to that long-term return assumption, where we expect returns to be both above and below that line. Our relative returns compared to the industry, we expect to vary somewhat over short time horizons. Our fund looks a little bit different, so we're going to behave differently during different time periods. Our actual experience has reflected that in about a third of any individual years we've been in the bottom of the database, but over that longer time period, we remain in the top decile. And we expect PERS simple approach will continue to be competitive on a relative basis over long time horizons. While my report today and provided materials through the 2024 fiscal year, I wanted to take the opportunity just to give you a quick update on returns for the start of the 2025 fiscal year. As we sit here this morning, PERS returns through today for the 2025 fiscal year are up roughly 5.5% fiscal year to date, so a strong start to the fiscal year. Again, not necessarily indicative of where we'll end the year, but definitely off to a good start. And as we stand this morning, PERS portfolio sits at $67.4 billion in assets. I guess looking forward over the long term, one of the silver linings, I would say, to the higher interest rate environment that everybody's is experiencing, anybody going out to take on a mortgage right now is certainly feeling it, or an auto loan in this normalized interest rate environment. But one of the silver linings to the higher interest rate environment, or I would call it a more normalized interest rate environment, is that we can expect with 10-year Treasury bonds as of this morning currently yield around 4.4%. Go back to 2020, 10-year Treasuries were yielding less than 1%. That higher interest rate environment implies that we should have a smoother path going forward to trying to achieve that 7.25% long-term return, since we're getting higher income out of the safety bucket or the Treasury allocation in the portfolio. And with that said, that concludes my prepared remarks. I'm certainly happy to answer any questions.
Thank you very much, and I appreciate your expertise, and thank you very much for doing that. Any questions up north?
Chair, yes, a couple of brief questions, if I may.
Please.
Thank you, Mr. Edmondson, and thank you for your judicious work here with the system. My question is, we don't know what the future holds, and if there's a bear market ahead, how do you see the system handling that? If we look at the returns that we've had during times of crisis in 08 and 09, 2022, going back to 01, 02, if something like that happens, how do you see PERS, handling that?
Yes, thank you for the question. And again, Steve Edmondson, Nevada PERS. We won't be immune to market volatility. However, as part of that silver lining that I was discussing earlier, in regard to the amount of risk that we have to have in the portfolio, one of the benefits of a higher interest rate environment is that we're actually able to maintain an investment approach at this point that has a lower level of expected volatility going forward. During the last fiscal year, PERS board, a recommendation of staff, we significantly reduced our risk posture in the portfolio, given the higher interest rate environment, and that lower risk posture of the investment portfolio should help buffer returns going forward. Again, we won't be immune, but historically our allocation exclusively to treasury bonds and our fixed income allocation has provided that buffer during volatile time periods. If you go back to 08 and 09, PERS results, despite our higher allocation of publicly traded stocks, remain competitive relative to the industry. So at the end of the day, we won't be immune to volatility over short time periods, but our lower risk profile at this point should help smooth the ride going forward.
Thank you very much. I appreciate that. And Chair, with your indulgence, one brief follow-up.
Please.
I appreciate the breakdown of investment categories on pages 419, 420 for the PERS, legislative retirement, and judicial retirement. What right now is our investment in the cryptocurrencies, virtual currencies? Is that a large part of the investment in PERS, or is it minuscule? I just wonder if you could speak to that.
Yes, thank you for the question. Again, Steve Edmondson, Nevada PERS. Our exposure is effectively zero. We don't own any cryptocurrency within the portfolio. We will have some exposure to companies in the venture capital space that might have some offset exposure within the industry, but we don't have any direct exposure to the cryptocurrency. One of our, I guess, key tenets of the portfolio is that we won't put anything into the portfolio unless it's at least 5% of total fund assets. If it's below 5% of total fund assets, it simply won't move the needle to total fund returns. For instance, a 50 basis point or a 1% allocation to, say, commodities would not provide a meaningful buffer to, say, in an inflationary environment, nor would, say, a 50 basis point allocation of cryptocurrency ultimately do much, if anything, to total fund returns one way or the other. So we try to keep our investment approach at each piece of the investment portfolio is designed to play a role and will play a significant role. And unless we see an asset class that fits in with our high quality bias within the portfolio, we won't include it in the allocation. And to date, we don't have any direct exposure to cryptocurrency.
Thank you very much. I appreciate the answer, Mr. Edmondson, and all your hard work. Thank you, Chair.
Thank you very much. I don't think I see any additional questions, so thank you very much. And we can go on to the next section. Thank you.
Madam Chair, Tina List, Executive Officer of the Retirement System. Item 5.5 in your packet on page 427 is an update on the benefit provided to certain education employees pursuant to NRS 391.165. This benefit was designed to be an incentive to certain employees to work at schools that have been designated as needs improvement, or at least 65% of the pupils or children who are at risk. Additionally, any teacher who holds an endorsement of mathematics, science, special education, or English as a second language and meets all the eligibility requirements and who have been employed for 1 year in the area of endorsement may be entitled to the benefit as well. Section 4 of AB 1 of the 23rd Special Session repealed this benefit effective July 1st, 2007 and phases it out over time. If an employee elected to continue in the 1/5 of a year purchase program, participation ceases when the employee has received after election 1 year service credit under the program. And if you think about that, 1/5 of a year to get 1 year would take 5 years. However, because of people moving in and out of positions, we still have some people in 2023 and 2024 that were eligible for this benefit, although it has greatly decreased because of the elimination of the benefit in 2007. The spreadsheet on page 429 reflects purchases for calendar years 2023 and 2024. In calendar year 2023, the system received $454,371 for 65 purchases. And in 2024, it was $97,710 for 11 purchases. Since inception, the system has received $149 million for 41,847 purchases. And over the last 2 years, this has been limited to Clark County School District and Washoe County School District. And I'd be happy to answer any questions.
Thank you. I have one. Did they have to, the people that are still in the system, did they have to designate that they wanted to do this back when they were at the Title I school? In other words, they can't right now say, oh, I was at a Title I school in 2007 and I now want to join and do this.
Yes, Tina List, for the record, yes, I think the law provided that they had to opt to remain in the 50-year program versus some other type of incentive in the 2007 time period. So this is limited to people who made that decision long ago.
Okay, thank you. I agree. I just wanted that to be clarified. All right. Any questions up north?
No, Chair, thank you.
Thank you very much. I don't believe I see any down here, so we can move on to the next section. Thank you.
Steve Edmondson, Chief Investment Officer, Nevada PERS. Agenda item 5.6 provides a status report on the administration and investment of the Retirement Benefits Investment Fund. Just by a quick way of background, the Retirement Benefits Investment Fund and Retirement Benefits Investment Board were created and enacted from Senate Bill 457 of the 2007 session, which established the board and the Retirement Benefits Investment Fund as a vehicle for government entities that wish to participate in funding future OPEB liabilities and provide an investment vehicle for them to do so. Last fiscal year, the Retirement Benefits Investment Fund produced a return of 14.7% and finished the year with $906.6 million in assets, with 12 participating local entities, all local government entities currently participating within the RBIF portfolio. Since our last update, there have not been any changes to the fund administration, which continues to contract out for administrative services. Investment and accounting services are provided by ultimately Nevada PERS. Since inception, the RBIF fund, I think interestingly, has produced a return of 7.5%. Given its challenge starting date, the fund, the RBIF structure was adopted ultimately in 2007 and then initially funded in 2008, which, if you recall, was an acutely difficult time period for markets during the great financial crisis. But I think the fact that the fund has produced that 7.5% long-term return, given the difficult starting point, is a good illustration of what time horizon, a longer time horizon can produce in investment markets, and also provides a good touchstone that our 7.25% long-term return assumption remains viable for the PERS fund. And with that said, I'm happy to answer any questions about the RBIF portfolio.
Thank you very much. Any questions up north?
No, Chair, thank you.
Thank you. Don't think I see any down here. Thank you, Mr. Edmondson, again. And that means we can move on.
Good morning, Madam Chair and members of the committee. For the record, my name is Cabrina Fazer. I'm the Operations Officer for the Public Employees Retirement System of Nevada. We would like to provide an update on the status of the new pension administration system, PERS, under agenda item 5.7. Work began with the software vendor, Tegrit Software Ventures, on February 22nd of 2021. An employer advisory group was established and they meet regularly. This has been a beneficial resource for communication and collaboration. Data cleansing efforts have been ongoing since 2019. In preparation of the new Paris system, 99.996% of the data from our current system, Carson, has been converted to the target staging database. Several milestones have been accomplished since the last IRBC meeting earlier in 2024. This includes benefit functionality, calculators, workflows, and user interfaces have been tested and are programmed in the Paris system. In addition, staff is working in parallel tracks for retiree services and accounting functionality for this phase of the project. Our first group of employers transitioned reporting their monthly retirement reports in the Paris system in February of 2024. This past year, the focus of phase 3 employer reporting has been on training and transitioning those employers. There are currently 182 employers that are reporting their reports in the Paris system. The Paris project has been moving along well. We have received positive feedback from the employers who have transitioned to Paris. We even had a group of employers at our recent liaison officer conference that were part of a roundtable discussion regarding Paris. There have been some mutually agreed upon changes which have impacted the project timeline. Their examples include holding off on transitioning the employers to ensure that their suggestions were programmed and ready prior to the go live. There was also the opportunity to upgrade to the framework NXT for ease of maintenance and other benefits, as well as making sure that the project is a successful implementation. Rather than risking quality of the project to meet the original go live date of January of 2025, staff collaborated with the PAS vendor, Tegrit, along with our project oversight vendor, ProValiant, and proposed a modification to the project timeline, deliverables, and payment milestones to the Retirement Board. The Retirement Board authorized the change request for the timeline and payment schedule at their May 2024 meeting. This changes the final deployment date from January of 2025 to June of 2026. The overall cost increase is approximately $4.2 million. Even with this additional cost, the system remains within its original projected budget for the overall project. The overall goal of this project has always been to create a modernized user interface with enhanced functionality to serve our members, retirees, and employers. Those are my prepared remarks, and I'm happy to answer any questions the committee may have.
Thank you very much, and thank you for your hard work on this. Any questions up north?
Yes, Chair, a brief question.
Please.
Thank you, Chair.
Please.
Thank you for the presentation. I just wanted to get that date right. The January 2025 startup date of going live is now being pushed to 2026, but I didn't get what month?
Sabrina Fazer, for the record, that date is June of 2026.
Okay, thank you. And a brief follow-up, Madam Chair, with your permission?
Please.
Thank you. You mentioned some of the challenges in trying to get the system modernization project, the Paris project working and working with the vendor. Do you feel that, and the June 2026 date, and I think the 4.2 million, that additional cost, that's pretty firm, or is there a possibility it might get pushed back further, or it might become more costly to try to implement this?
Thank you, Senator Orenshaw. For the record, this is Sabrina Fazer, Operations Officer, Nevada PERS. We had a really hefty goal of transitioning all employers within a year. Until all of those employers have transitioned, and some are taking a little longer based on them being in the middle of their own computer projects and our updates. So we're watching that with the schedule at this time. We're also watching to see if that will impact any cost, because there's the chance that once one of these larger employers transition, there may be programming changes that they suggest or they may need prior to go live. So at this time, it's definitely a risk that we are watching and being aware of, but I don't have anything else to report at this time. It's just a risk we are navigating.
Well, thank you. Appreciate all your hard work on the project and certainly trying to get all the new computer systems working. That's a big task, I think, in any organization. Thank you, Chair, for your indulgence.
Thank you very much. And I don't think I see any questions down here. So thank you very much. Thank you, Ms. Lees, for your team and all their expertise. This is an important benefit to all of our public employees. So thank you.
Thank you for your time.
Thank you. All right. So with that, we will go to item number 6, second public comment. And if you are listening, you may call in at 888-475-4499. And when prompted, put in the meeting ID 861-7260-3549 and press pound. And if you have any issues, I guess, let us know. Otherwise, we will go to public comment in Carson City first.
And Chair, I don't see anyone coming up to the table here in Carson City.
Thank you very much. Anyone here in Las Vegas? Seeing none, thank you. We'll go to the phone lines. BPS, when you're ready.
Thank you, Chair. The public line is open and working, but we have no callers at this time.
Okay, thank you very much. We wore everybody out. All right, and with that, if there are no other public comments, then we will adjourn. And with that, thank you very much. This meeting is adjourned. Thank you.